Greetings and salutations again, everybody. We're going to turn our attention here to the ovarian neoplasms and cancer. We're going to spend most of our time here talking about ovarian cancer, and that is because it is the fifth leading cause of cancer death in women, and so it's important. It's also important because it is one of those cancers that we don't typically diagnose until it's too late. And it's a sad fact because there are signs that herald ovarian cancer, but we typically don't pick up on them because they're very nonspecific. So we'll talk about that. We'll start, as usual, with a vignette. A 54-year-old woman presents to your clinic complaining of progressive bloating over the past month. She says that she has also had some mild lower abdominal pain, which her previous physician had attributed to irritable bowel syndrome. It is not improved with a high-fiber diet. She also says that she has had some urinary frequency and urgency, but was told that this was from menopause. She is a G1P0, which resulted in a spontaneous miscarriage. She has never taken contraceptives and is presently menopausal since age 50. There is a 40-pack-year smoking history. Past medical history is significant for diabetes mellitus, controlled with a diet and metformin. Physical exam is remarkable for a non-tender distended abdomen with a positive fluid wave. Pelvic examination reveals a nodular, fixed, right-sided adnexal mass. There is no cervical motion, tenderness, or discharge. What's our next step here? So we have a pelvic mass. We want to image it. Okay. So we're not really suspicious of pregnancy in this patient because she is postmenopausal. 54, you might get a beta HCG, but we're going to start. The best first test is going to be a transvaginal sonography. So we get transvaginal sonography, and it reveals an 8.2 centimeter ovarian mass with multiple septations, solid and cystic components, and neovascularization on Doppler. This is extremely concerning. So we also note that she has ascites, positive fluid wave. That's behind that progressive bloating. And so any woman with a ovarian or with an adnexal mass and ascites is ovarian cancer until proven otherwise. And really, any postmenopausal woman with an ovarian mass is going to be worked up for cancer. We're very concerned in these women. Okay, so some of the signs, of course, of progressive bloating. This is typically due to seeding from the tumor. It gives off tumor cells into the peritoneum, and that fluid then expands because you have an osmotic pressure, a shift of fluid into the peritoneum. Other things, the lower abdominal pain, very nonspecific, often accompanies ovarian cancers, however. So it would be reasonable to attribute it to IBS if, it's idiopathic. But you're not going to do a full workup for ovarian cancer on every single woman that comes in with lower abdominal pain. So you really have to take the constellation here. You have this bloating, you have lower abdominal pain, you have urinary frequency and urgency, and then ascites, and that's the most concerning here. Okay, so when you have this constellation of symptoms, then in that case you definitely want to do a pelvic examination and feel for a mass. And when you appreciate a mass, you want to visualize it. So these are our important features here. Now, if you watched the talk on ovarian cysts, which I recommend you do, I would recommend watching that first before you watch this. There are some guidelines for referring a pelvic mass for further workup. So a pelvic mass can be any kind of mass. It can be a cyst, it can be a tumor. And so there are guidelines for referring a mass for further workup. So any patient with ascites and a mass, they're going on for further workup and they're probably destined for surgery. Any evidence of abdominal or distant metastases, that's going to be difficult without imaging to note. Some patients, particularly postmenopausal women, you're going to get a CA-125 level with any abdominal or with any pelvic mass, particularly if it's one of those masses that are fixed and nodular. And the reason is because the most common cause of pelvic mass in a woman is going to be a cyst, an ovarian cyst, as the most common cause of an ovarian mass in women. Now, who does ovarian cysts typically occur in? It occurs in premenopausal women because ovarian cysts are typically functional. So when you have a postmenopausal woman with a mass of the ovary, that is not something we would suspect because she's not ovulating. So in that case, it would be good to get a CA-125 level on her right away. Now, CA-125, as we're going to talk about, is not very good, not as good as you might think. It is a marker and it is elevated in a lot of epithelial ovarian cancers, but you can get false positives, things like pregnancy, endometriosis, fibroids. They can all cause elevated CA-125. And then in very early ovarian cancer, where you might otherwise suspect ovarian cancer, you get a CA-125, it comes back negative. You may still have ovarian cancer if it's early on enough, but the CA-125 level has not gone up to that 200 unit per mil threshold. So you can't rule out ovarian cancer with a negative CA-125, and you can't necessarily say the patient has ovarian cancer if they've got an elevated CA-125. So it helps you. If you have a positive CA-125, it supports the diagnosis of ovarian cancer, but it's not pathognomonic by any means. There's another test that they've came out with more recently called the OVA1 score. This is a biomarker, I believe, and they take a titer of this. It's measured, you get a score back, and you can plot this. It's based on age. The threshold is going to be based on age. So premenopausal women, if it's greater than 5, it's consistent with ovarian cancer. Postmenopausal women, if it's greater than 4.4. Don't worry about this for the test. This will not come up on the test. CA-125 may come up on the test. What we use CA-125 for is to help support a diagnosis of ovarian cancer and also to check response to treatment when we start a woman on chemotherapy to see if she's responding appropriately. CA-125 is not used for screening, not for routine screening. Okay? Unfortunately, it is not useful for that. So these are all the ovarian masses. Here we're going to focus on the ovarian neoplasms, and we're not going to talk about all these in detail. The most common type of ovarian neoplasm is the epithelial tumors. They make up 65 to 70% of all ovarian tumors, and they make up 90% of all ovarian cancers. So most ovarian neoplasms are benign. But if you have an ovarian cancer, 9 times out of 10, it's going to be an epithelial tumor. And when we talk about the treatment here, we're going to talk about treatment for epithelial tumors. The treatment for these other tumors are a little bit different. So the ovarian epithelial tumors are the most common. Among these, the most common ovarian epithelial tumor is a serous cystadenoma. Do not worry about differentiating these, but you should know that ovarian epithelial tumors are the most common ovarian neoplasm and the most common ovarian cancer. Ovarian germ cell tumors are the most common type of ovarian cancer in women under the age of 20, including pediatric patients. This can be teratomas, which can be immature, mature, or monodermal teratoma. And that includes the struma ovarii, which can cause hyperthyroidism symptoms in a patient, and they don't have any kind of disturbance in their thyroid, but rather they've developed thyroid tissue in their ovary. Teratomas can be benign or malignant. The immature teratoma is malignant, and this makes up about 20% of these cases. Other forms of ovarian germ cell tumors are the dysgerminoma, the endodermal sinus tumor, choriocarcinoma, embryocarcinoma, and polyembryoma. Now, you will want to have a passing familiarity with these tumors because the USMLE will like to throw at you tumor markers so you know what tumor markers correlate with each of these tumors. And a lot of these tumors can also occur in boys and men. So when you get these tumors, they derive from germ cells, which these germ cells could either be germ cells for sperm or germ cells for egg. And so remember, the ovaries are homologous to the testes. So here we're talking about cancers that could be testicular cancer in boys and men. Sex cord and stromal tumors arise from hormone-producing tumors in the case of sex cord tumors, and stromal tumors, we're talking about the stroma, and that would be the fibroma. So these tumors are going to create the granulous apical cell tumors, and the Sertoli Leydig cell tumors are going to produce hormones, estrogens and androgens. Okay. So we'll talk briefly about the epidemiology. We'll talk about the pathophysiology of these three classes, and then we're going to primarily be focusing on the ovarian epithelial tumors. Like I said, 90% of the malignant ovarian neoplasms are epithelial tumors, so I want to focus on that. If you get a question on treatment related to ovarian neoplasms on medical board tests, it's going to be focusing on ovarian epithelial tumors. So the epidemiology, 1 in 70 women will develop ovarian cancer in their lifetime. So quite common. It's the 9th leading cause of cancer overall in women. And then 1 in 95 will die from ovarian cancer. So quite a few. If you think 1 in 70 develop ovarian cancer, 1 in 95 die from ovarian cancer, this is a relatively deadly cancer. Overall, it's the 9th leading cause of cancer in women, but it is the 5th leading cause of cancer death in women. The average age at diagnosis is 61, and remember that there are ovarian tumors, ovarian cancers that can happen much younger. I've seen 18, 19, 20-year-old women that have had ovarian cancer. So it can definitely happen younger, but typically when we're talking about those tumors, they tend to be the non-epithelial tumors. Because epithelial tumors are so common, 90% of cancers, you're going to have a much older age as an average. So the average age of diagnosis is 61 years, 2/3 are older than 55. So this is primarily a problem of older women. There are hereditary ovarian cancers, and primarily these are women that carry the BRCA mutation, and so they will have an increased predilection for breast cancer and ovarian cancer. There's a higher incidence in whites when we're talking about epithelial tumors, but when we talk about germ cell tumors, that's got a higher incidence or a predilection for blacks and Asians. Women with familial cancer syndromes or the BRCA mutation carriers are at considerably increased risk. So here we're talking about Lynch syndrome, which remember increases your risk of colon cancer, various other cancers, endometrial cancer, and then, like we said, the BRCA mutation. So here's some notable ovarian cancer deaths. You can see that this affects women at all different kinds of ages, but usually a little bit older. So Gilda Radner was she was a comedian on Saturday Night Live. Coretta King is the widow of Martin Luther King Jr. And Rosalind Franklin, you probably know who she is. She helped discover the DNA molecule. Now with Rosalind Franklin, a little bit different here. Note how young she was. She actually probably developed the cancer because she was in front of X-ray machines and not using protective gear. So that may have been behind it. Now, if you look at the relative incidence of ovarian cancer to other cancers, it is not as common as endometrial cancer, which is quite common. But when you look at mortality, ovarian cancer is much more deadly than the other cancers, 58%. So the majority of gynecologic cancer deaths are from ovarian cancer, whereas the majority of gynecologic cancers in general, just as far as incidence, are endometrial cancers. Endometrial cancers, however, have a much better prognosis. Ovarian cancers, not so much. So ovarian cancers, a little bit more rare than endometrial cancers, but a much higher rate of death. So this is what we already talked about, these tumors. The ones I put here in red are the ones that have a high predilection for cancer. So a lot of the germ cell tumors are cancerous. And then the serous cystadenocarcinoma, which makes up the majority of ovarian epithelial tumors. There's some other ones as well. I just want to talk briefly about some of these, and we're not going to spend a lot of time here, but the endometrioid carcinoma is a cancer that often coexists with endometriosis. It also has a predilection to coexist with endometrial cancer. So that's something to consider there. I think that's all I wanted to talk about. Actually, we'll touch on these other ones a little bit. Okay, so you can see here that the majority of cancers are surface epithelial cancers, namely the serous adenocarcinomas make up a lot of them. And we have endometrioid cancer, adenocarcinoma. Borderline adenocarcinoma is what's known as a low-grade malignancy. And so these have a tendency to be a little bit better prognosis than the rest of them. You can see just a very small number, though, are the germ cell tumors and the sex cord stromal tumors. So most of these cancers are going to be the surface epithelial cancers. So the epithelial tumors are derived from ovarian surface epithelium. Most commonly, these are going to be the serous adenocarcinomas. They are typically found on sonography as these partially cystic lesions, usually with some kind of solid component as well. They're slow growing and usually quite advanced at diagnosis. The average stage at diagnosis is 3C, so quite advanced. It makes up 65 to 70% of total ovarian tumors, but 90% of ovarian cancers. These spread by local invasion. Most of the time, you get what happens is these cells will slough off. They get into the peritoneum, and from the peritoneum, they then can invade other structures, namely the omentum. They can get into the uterus. They can get into the mesentery of the bowel, surface of the liver, and so forth. There's increasing evidence that suggests that most high-grade serous adenocarcinomas, cystadenocarcinomas, originate actually from the epithelium of the fallopian tubes and then spread over to the ovary that way. So that's something new that we're discovering. And then, as mentioned, there's an increased risk of epithelial tumors in women who carry a BRCA mutation. Germ cell tumors are derived from the cells that are destined to become eggs. It's the most common cause of ovarian neoplasm and cancer in females under the age of 20. They are rapid growing, and usually they're stage 1 at diagnosis, and this confers a much, much better prognosis. These germ cell tumors. They can be teratomas, which don't have any biomarkers, and then they can be these other germ cell tumors, some of which have biomarkers you'll want to be aware of for the test. Sex cord and stromal tumors are derived from the hormone-producing cells, in the case of sex cord tumors, or the cells that make up the interstitium of the ovary. The age of onset is variable. The sex cord tumors, so Sertoli-Leydig, theca granulosa tumors, they produce hormones, and hence they can lead to symptoms that are not seen in other tumors. So the Sertoli-Leydig cell tumors create androgens in women that can cause virilization, so things like acne, hirsutism, receding hairline. On the other hand, the granulosa theca cell tumors, they create estrogens, and so they can cause intermenstrual spotting, any kind of menstrual disturbance. They can cause precocious puberty if this happens in a prepubescent child, so consider that. So the tumor markers you'll want to be aware of course, for epithelial tumors, it's a CA-125, and then for some of these germ cell tumors, the dysgerminoma, this is the most common malignant germ cell tumor. What you get out of this is LDH. The endodermal sinus tumor is also known as a yolk sac tumor, and I like yolk sac tumor better, even though endodermal sinus tumor is probably the more correct term. But yolk sac tumor makes sense because the yolk sac in a fetus is what creates alpha-fetoprotein. And so it makes sense then that the endodermal sinus tumor is going to cause an increased alpha-fetoprotein. Choriocarcinoma is that tumor that's on the malignant end of the gestational trophoblastic disease spectrum. It is derived from placenta, and so it makes sense that this creates HCG, human chorionic gonadotropin. Choriocarcinoma, chorionic gonadotropin. Embryonal carcinoma itself does not cause any kind of tumor marker, but embryonal carcinoma tends to coexist with other germ cell tumors, endodermal sinus tumor, cardiac carcinoma. So you may see alpha-fetoprotein or HCG elevated. How does this present? So here we're going to primarily be talking about the epithelial tumor because this is the most common, and I could have spent 3 hours talking about all these different tumors and it wouldn't have been very high yield. So I want to keep this high yield here. The history of symptomology is going to typically be asymptomatic until advanced. However, if you were to ask the woman who has ovarian cancer, did you have bloating, abdominal pain, anything like that leading up to your diagnosis? A lot of them will say yes. But the problem is it's easy to see that in hindsight, not so easy to take these symptoms and say, oh, I probably have ovarian cancer. Because a lot of people have lower abdominal pain, more or less some abdominal distension, bloating, early satiety, very, very common. The pelvic pressure can lead to increased urinary frequency and urgency. Again, something very common in menopause. So it's often goes under the radar. Physical examination, virtually all patients with ovarian cancer will have a solid fixed irregular mass. Once these cells get into the peritoneum, you can get ascites, and there can also be metastasis to the umbilicus. Now, this isn't very common, but it commonly comes up on the test. So you want to be aware of this. I'll show you a picture. It's called the Sister Mary Joseph nodule. There's another syndrome called Meigs syndrome, and this is a triad of an ovarian tumor, ascites, and right hydrothorax. I'm not sure how the right hydrothorax comes up there, but I do know that the right hemidiaphragm is a common place of metastasis, and so it's possible that that's causing the hydrothorax. So this is Sister Mary Joseph Dempsey. She was a Roman Catholic nun, worked at St. Mary's Hospital in Rochester, Minnesota, not very far from where I live. And she was an assistant at St. Mary's Hospital, a surgical assistant, and she noted that these patients that have ovarian cancer, some of them have this weird nodule on their belly button. And eventually, this was correlated with ovarian cancer. So St. Mary's Hospital down in Rochester is now known as the Mayo Clinic. You may have heard of it. This is the Sister Mary Joseph nodule, so quite discreet and obvious. Ovarian neoplasms and cancer for diagnosis. The pelvic ultrasound is going to be the initial investigative modality of choice when a mass is suspected. So you're doing a pelvic exam, you feel a mass, you should instantly think ultrasound, either transabdominal or transvaginal. So when ovarian cancer is suspected, particularly when we're talking about an ovarian mass in a postmenopausal woman, you should go ahead and get CA-125 titers. You might not do it in a premenopausal woman because a lot of those ovarian masses are just ovarian cysts. But in an older woman, it would be prudent to get a CA-125 right away. Suspicion for ovarian cancer should be followed by CT for treatment planning. So you have a postmenopausal woman with an ovarian mass, maybe comes back with an elevated CA-125, you're definitely suspecting ovarian cancer. Or let's say you have a premenopausal woman with a fixed pelvic mass and it's not going away. You might think, maybe it's a cyst. Check her back up in 6 to 8 weeks, hasn't gone away. You feel it, maybe it's gotten a little bigger. Then you're going to get a CT and a CA-125 titer for that matter. But a CT is done for treatment planning. So at this point, we've already determined that these women are going to get surgery or some kind of surgical exploration. We're going to remove the ovary that has the mass. So the CT is primarily for treatment planning. It's not really for diagnosis. So when you get sono here, some of the features that you're going to see is multiple septations. There's going to be both cystic and solid components. So you have some solid component down here. You have the septations. A lot of times you can have these papillary excrescences. And then if you look at the size, a lot of these tend to be much bigger than the cysts. So 6, 7, 8 centimeters and beyond. There can also be degrees of neovascularization. Remember with the, so here again we see, I want to point out, you see both solid and cystic components, whereas in ovarian simple cysts you tend to see just cystic component. Now, with the corpus luteum cyst, you can have some neovascularization, or vascularization really, but it tends to be around the periphery of the cyst. On the other hand, when you have vascularization within the cyst, that's more concerning for cancer. Okay, so here another papillary excrescence into the tumor. So we already talked about this, but the guidelines for referring pelvic mass for further workup, definitely any kind of ascites, any evidence of abdominal or distant metastases. So if you feel lymph nodes, elevated CA-125 level, and then nodular fixed masses, or if you get that OVA1, then that would come back elevated, then you'll want to probably do surgery. So the surgery consists of multiple components, and this is all going to play a role in how we stage the cancer. So we want to get peritoneal washings, definitely, because that will tell us if we have seeding into the peritoneum. Now, if you have a woman with ascites, almost for sure she's seeding into the peritoneum, because that's what's causing the ascites. But either way, we want to get peritoneal washings, because there may be seeding, but no ascites yet. Or you can just aspirate the acidic fluid. You want to palpate the peritoneal surface with your gloved hand. Now, a lot of times you'll do these laparoscopically, and in that case you wouldn't be able to do this. So that's one of the limitations of laparoscopic surgery. But this, you're feeling for peritoneal metastasis, which is different from peritoneal seeding. You'll do an extrafascial hysterectomy, that should say end bilateral salpingo-oophorectomy. There's one exception, we'll talk about that in a little bit. Peritoneal biopsy, primarily here we're going in the undersurface of the diaphragm, just randomly getting a sample to see if there's any diaphragmatic spread. And then, very importantly, we're getting lymphadenectomies of the pelvic nodes and the infrarenal para-aortic nodes. So there's para-aortic nodes all the way up the aorta, but we want to check infrarenally, so down lower. Now, some women will be younger with the diagnosis of ovarian cancer. These women may want to remain fertile. And so a minority of women, we can do fertility-sparing surgery. So if the tumor is localized to one ovary and there is no spread beyond the capsule of the ovary, the capsule is intact, in that case you can just take the one ovary out. So what you'll do is you'll go in for the surgery, rather than getting a bilateral salpingo-oophorectomy, you'll just get a unilateral salpingo-oophorectomy, keep the uterus in, of course, and then you'll check the pathology and see if the capsule is intact. If there's any kind of cancer on the outside of the ovary, you're going to have to take the other one out, because it's very likely that it is spread. So very, very reserved cases, you can do a unilateral salpingo-oophorectomy. But if she's done having kids, then you just want to take it all out, no matter what. So here's how you stage ovarian cancer. If it's confined to one ovary and there's no capsular invasion, capsule's intact, it's 1A. If it's two ovaries, capsules are intact, it's 1B. If there's capsular rupture, or if there's tumor on the surface of the ovary, or if there is malignant ascites, it's going to be 1C. And this is whether or not there's one or two ovaries, doesn't matter. Stage 2 involves pelvic extension, either spread to the uterus or tubes, to other pelvic organs, or if there's malignant ascites. So basically, if you're ever staging C for 1 or 2, you're looking for ascites. So if the capsules are intact, but you have malignant ascites, it's 1C. If you have spread to adjacent pelvic organs and you have malignant ascites, it's going to be 2C. Stage 3 involves peritoneal metastasis. So you'll see these peritoneal mets. If they're very, very small, it's going to be 3A. If they're less than 2 centimeters, it's going to be 3B. And if it's greater than 2 centimeters, it's going to be 3C. So this is why we get sampling of that diaphragmatic area. We're looking for microscopic metastasis. These other metastases, you'll be able to see them, and that's why we're palpating around the peritoneum. Now, if there's lymph nodes, regardless of wherever it might fall on these stages, if there's positive lymph nodes, then it's going to be at least 3C. And remember, 3C is the most common stage of diagnosis. Stage 4 is going to be distant metastases beyond the peritoneal cavity. Okay, don't memorize this for the test. But it's good to know for practice that ovarian cancer is most commonly diagnosed at 3C. When I say ovarian cancer, I mean epithelial ovarian cancer. Now, the other cancers, germ cell tumors, sex cord stromal tumors, are more commonly diagnosed earlier on, stage 1. But for the most common form of ovarian cancer, the epithelial tumors, most common stage of diagnosis is 3C. Now, so 50% are diagnosed at stage 3. You can see a good amount are diagnosed in stage 1, and then the rest are at 2 and 4. The 5-year survival obviously is going to correlate to the stage at diagnosis, but it's a very sharp drop after stage 2. So you can see at stage 3, when most of these tumors are diagnosed, only about a 4 in 10 chance of surviving. So this is just the same thing as what we talked about, just in picture form. What do we do for treatment? So women with stage 1C epithelial ovarian cancer, so that means the capsule has been compromised, or beyond, must receive chemotherapy. So you're going to do all the surgery, you're going to take all those organs out, and you're then going to do chemotherapy. And the mainstay of chemotherapy in epithelial ovarian cancer is carboplatin and paclitaxel. We're always doing platinum-based chemotherapy in women with epithelial ovarian cancer. 20% of women that receive this regimen will develop recurrence in 5 years because some ovarian epithelial cancers are resistant to platinum-based chemotherapy. Now, when we're talking about, and I doubt this will come up on your test, but if you're talking about germ cell tumors, which are the ones that tend to happen in kids, or sex cord and stromal tumors, our chemotherapy of choice is known as BEP, B-E-P. And that is bleomycin, etoposide, and platinum, cisplatin. So for follow-up, we want to do regular examinations quite regularly for the first 5 years, every 3 months for 2 years, then every 4 to 6 months for 3 years, then every year thereafter. Don't memorize that. But no, you're doing regular examinations. If the CA-125 level was elevated when you diagnosed the ovarian cancer, then you should get CA-125 levels at every visit, because that will tell you if the woman is responding to the chemotherapy. And we would expect that a woman who had ovarian cancer with an elevated CA-125, if it comes back, the CA-125 is going to go back up. And then CT should be performed if there's any suspicion of recurrence. So if the CA-125 goes back up, if you feel a new pelvic mass, she starts losing weight, develops ascites, get a CT